Good morning, everybody. Um, I have the distinct pleasure this morning of introducing Dr. Bhavan Modi, who is one of our fourth year residents. He came to us from the University of Alabama, where as an undergrad, he studied um, biomedical and health sciences, and then molecular biology and psychology. And then as a graduate, he did his biomedical and health sciences degree. Now he's one of our wonderful fourth year residents, and he is actually interested in epilepsy, is what I understand. As you can see on the screen today, he's going to be talking about expansion of newborn screening and gene therapy.
Hi, thank you, Dr. Mangum. Yeah, so as Dr. Mangum said, my name is Bhavin, like oven with the B, Bhavin, and I'm in PGY4 at Phoenix Child Neurology. I chose to talk about newborn screening and how it relates to gene therapy because I'm also very interested in neurogenetics. Initially, when I started residency, I thought I was going to do a neurogenetics track, but as I've done more and more training, I think I'm getting a little bit more interest in epilepsy. But obviously genetics plays a huge role in that as well, right? But we'll get started. So today the objective. So what I want to do is talk about the importance of why we should expand newborn screening, and how that relates to gene therapy. What I also want to do is talk about some of the basics of gene therapy, so some of that basic science. I've kept it as superficial as possible to not bore everyone, but I do love the minute details of genetics, so I've included that. Also, we'll talk about some ongoing therapies, some successful therapies such as spinal muscular atrophy, and then also some future targets. And then we'll want to talk about how gene therapy also does unfortunately have some ethical dilemmas, so we'll discuss that as well. So we'll start off with some case vignettes, or really they're scenarios, but so case one, we have an infant who's diagnosed with SMA at 6 months of age. We know at that point the damage that has been done is irreversible. Um, while we can treat them, unfortunately, the damage that has been done, we can't go back and reverse that, right? Unfortunately, with the nervous system. Then we have case number two, or scenario number two, where a newborn is diagnosed with SMA at 2 weeks of age after a positive newborn screen. There's a confirmation test that's done, also shows SMA. So, patient is treated with gene therapy, and the child has normal development, motor development. And I think we can all agree that that is the scenario we would want for the patient. Just a kind of a positive outlook on gene therapy here with case number two. So, what is the significance of expanding newborn screening? Early detection could potentially lead to better outcomes. We'll talk about that as we get further into the PowerPoint. More diseases are being included in the newborn screen now as well. Currently, there are over 100 diseases undergoing gene therapy trials. 70 of those are rare neurologic disease, so a lot of focus on neurology now with gene therapy. And then we'll also again consider the ethical, the political, the logistical challenges that come along with gene therapy. So here's a slide of examples of all the neurologic diseases that are undergoing gene therapy. We obviously will not touch on every single one of these, but just kind of highlight. So spinal muscular atrophy, while we do have gene therapy for it, there are subtypes that we don't. There are leukodystrophies, particularly metachromatic leukodystrophy or MLD, and then also adrenal leukodystrophy that we'll focus on. And then we have all the other diseases as well, right? So we have epilepsy syndromes, even with our adult neurology diseases as well, right? So Parkinson's, Huntington's, which actually read an article about Huntington's. The gene therapy is in the works, potentially for approval for next year, which we'll kind of touch on as well. So just to start with, what is the definition of gene therapy? So this is per the National Human Genome Research Institute. Gene therapy is anything that uses genes to treat, prevent, or cure a disease. It works by adding either a new copy, a functional copy, replacing a defective copy, or gene editing, which can be considered kind of a little different than gene therapy, but we'll include it under the umbrella of gene therapy. So these are the three major methods by which gene therapy is done currently. So we can either replace a defective gene, we can silence a non-functional or dysfunctional gene, and then gene editing, CRISPR. So we'll talk about gene replacement first. Simple, we functional copy is introduced into the host DNA. Stem cells are taken out of either the bone marrow, the peripheral blood, or the umbilical cord, and the stem cells are then grown. The working gene or the engineered gene, if you will, is inserted into the host cells, and then those cells are reintroduced into the patient, and then we have a functional gene. And so that is gene replacement. Gene replacement is done through these three methods, or these are three major methods used currently. Really, the adeno-associated viral vectors is the major one, especially for neurologic diseases, by which genes are replaced. So the first one, there's retroviral vectors. These are actually my favorite. I love retroviruses. And so they're RNA viruses that have reverse transcriptase. So the RNA that is introduced is turned into DNA, as you can see in this picture. That DNA is then integrated into the host genome via integrase, and then we have production of the mRNA and a functional protein. So no disease. Yay. The Obviously all of these have advantages and disadvantages. So the advantage of a retrovirus is that because it does integrate into the host genome, the expression is long term. So potentially just a one-time therapy, and we don't have to worry about repeated therapies. Some of the disadvantages, with a few exceptions with the lentivirus, but one of the disadvantage is that retroviruses require non-dividing they will not transduce non-dividing post-mitotic cells, so neurons. They will not infect neurons. They would work on just the cells that are actively dividing, with the exception of lentivirus, which is what's used in therapy because that one does have the ability to transduce and transfect non-dividing cells. There's also potential for what's called insertional mutagenesis or oncogenesis because we are integrating a new DNA into the host DNA. There's potential for oncogenesis, so that is a disadvantage as well. There are adenoviral vectors as well. These are DNA viruses that will transfer its DNA or the DNA that we engineer into the host. It does not necessarily integrate into the host genome, though. It forms this little episome, and then that is expressed. Because it does not integrate, it does not last as long. So this would require repeated infusions. And so that's one of the disadvantages. Another disadvantage is that majority of the population has been infected with adenovirus because it is responsible for the common cold, conjunctivitis, very common diseases. Sorry, I thought there was a question. So because majority of the population is infected with this, they will have antibodies, and so we introduce this virus, or excuse me, viral vector, and the immune system mounts a response, making the therapy ineffective. So that is another disadvantage. Uh, An advantage of adenoviral vectors, though, is that it can infect all cells regardless of where the cell is in the cycle. So it could infect neurons. And then this is probably going to be the major one to really keep in mind, adeno-associated viral vectors. These are adenovirus associated viruses. And the name is because they were actually discovered accidentally, if you will, as contaminants of adenovirus vector preparations. And these require co-infection, usually with adenovirus, but HSV as well. And so hence the nomenclature. The advantages is that it can also infect non-dividing cells, low immune response because there is no human pathology associated with this. Some of the limitations, though, however, with this is that you can only pack a little bit of DNA in it, so 4.7, which sounds like a lot, but compared to the huge human genome, it's actually a small chunk. And so that's one of the limitations. And then again, once again, keep this one in mind because when we talk about SMA, we'll talk about this one again. Here's a summary slide of the three vectors we just talked about. So the retro or lenti, like I said, with that one being the exception that can infect post-mitotic cells. And then, as you can see, it's kind of in the middle. level as far as capacity to hold the genome, so about 8 kilobase pairs compared to adenovirus, which can hold a lot more, up to 35. But once again, adenovirus, the one of the disadvantages, or many of the disadvantages include it, a huge immune response because most people are infected with it, and then also um, multiple infusions will be required since the effects are not long term. There's also the safety level that's included. That's a biosafety level that's determined by an agency that basically it is based on the how the preparation is done with these viruses, the infection, the health-related risk, essentially. And so, if you look at AAV, it kind of looks like the one to go with, right? Because there's no disease association with humans. And yes, it is a small chunk of DNA, but it is also a biosafety level 1, so the lowest you can be, it goes from 1 to 4. And then also the effects can last many years. Just for completion's sake, I included this slide. There are many other gene replacement methods as well. So HSV, alpha viruses, or pox viruses can also be used as vectors. I didn't see any clinical trials currently using these, but these are potentials. There are also non-viral vectors, so such as plasmids, right? So plasmids are closed circular DNA strand, which can be engineered to include the gene of choice, right? So now it's a recombinant plasmid. And then that can be also include promoters and ex repressors or expressors. So you could really regulate the expression of gene if you wanted to with plasmids. And so we're also using bacteria such as Clostridium as well in research. So, but nothing that I've seen thus far in clinical trials. The second method we have is gene silencing, also known as RNA interference. So at the transcription level, you could methylate the DNA, and we know methylation mutes the DNA, so it would turn off that gene. We can also build a RNA sequence that can bind to specific parts of the gene and block its transcription. At the translational level, we can also do, again, once again, the RNA synthesis and block the mRNA of the mutated gene, blocking the production of the protein. So earlier I did mention Huntington's disease, and so Huntington's disease, the gene therapy actually, obviously a very small study, 29 patients had 75% reduction in symptoms over 3 years. The reason why I'm mentioning this is because what they did is actually it's a surgical procedure where they insert a microRNA into the striatum, where Huntington's disease is the problem, and it actually blocks the transcription of Huntington protein. So it's really this type of therapy is gene silencing. And then we have gene editing as well. So CRISPR, I think we've all heard about CRISPR and the big chaos it created when it first came out and the excitement, I guess, if you will, not chaos. But so it is really it's an RNA with scissors or RNA with endonuclease. So we edit the gene, we cut out the gene that is defective, and there, no issue. So now let's actually talk about the gene therapies that are success going on, and then also some future targets we could think about. So, spinal muscular atrophy will kind of serve as the poster child for success in gene therapy because we've seen so much great progress with it. Um, so, spinal muscular atrophy, what is it? It's a group of autosomal recessive disorders, particularly affecting motor neurons in the spinal cord. It used to be the second, excuse me, it probably still is. I'm not sure if there's an updated statistics, but it is the second most common fatal autosomal recessive disease, second cystic fibrosis. The protein SMN1, or survival motor neuron protein, on chromosome 5 codes for a protein that modulates the growth of axons and also causes the arrest of apoptosis of motor neuroblasts. Type 1 being the most severe, which typically presents less than 6 months of life with muscle weakness, hypotonia, hyperreflexia, bulbar symptoms. And then without treatment, like I said, SMA is fatal, typically within the first 2 years, usually due to respiratory muscle paralysis. or aspiration pneumonia. And then there are other types of spinal muscular atrophy, type 2, type 3, type 4. Type 4 being adult onset and generally with a normal lifespan, but obviously we'll kind of focus on type 1 since that's the most severe and where we are doing the gene therapy. So in 2016, FDA approved Spinraza, which is an antisense oligonucleotide. So what it does is it alters the splicing of SMN2, not one, but SMN2, which is the backup copy, if you will, for that protein. So it alters the splicing to include an exon, or the most common exon, which is deleted in type 1, exon 7, to produce a protein, an SMN2 protein that is functionally equivalent to SMN1. It is injected intrathecally and it's done once a year. Then in 2019, FDA approved Zolgensma, which is a one-time gene replacement. And this one is the adeno-associated viral vector. Okay. And so once again, it does not integrate into the host genome, but it forms a little episome that expresses the functional gene. And once again, this is a one-time gene replacement. In 2020, then we had risdiplam, which is a daily oral small molecule. And this one is, once again, it also alters the splicing to include exon 7. It's considered a modifier molecule. And I believe our neuromuscular specialists at PCH, this is what they start once they find out a kiddo is diagnosed with SMA from the newborn screen. Then, so success, like I said, in SMA. So the START trial showed that in symptomatic treatment at 20 months of age, 11 out of 12 sat unsupported. There were no deaths, and there was no permanent ventilation as well. And then the second trial showed that in pre-symptomatic treatment, all 30 children achieved motor milestones within normal developmental time frame. There was also a non-randomized control trial in Germany and Austria that demonstrated that the children who who achieved independent ambulation was 4 times higher in those who were identified via the newborn screen and those who were treated pre-symptomatically versus those who were found out to have SMA later in life and treated later. And while I am obviously spitting this very positively, and it is, however, we do have to keep in mind that there are still a small portion of these children who, even after receiving therapy, will have some issues, the ones who tend to have more severe forms of it, of SMA. However, they're still walking, and their milestones are further than they would be without the gene therapy. So X-linked adrenoleukodystrophy is another one. So the Skysona is a lentiviral-based ex vivo autologous stem cell therapy. So it is the vector uses a lentivirus, which once again is a retrovirus. It uses the patient's own stem cells. Okay, so then they're taken out. So ex vivo autologous stem cell therapy. And it's approved for patients who are boys between 4 to 17 years of age with early symptomatic cerebral ALD. The There were two open label trials which demonstrated that 90% overall survival 2 years after receiving this therapy. And the study included 67 males, which I feel like is very high for a rare disease. We typically see very small numbers, right? Um, and unfortunately, though, and this is my argument for the newborn screen, ALD is not included in all newborn screens in all states. There's variation to variation based on state, and we'll talk about that. But we do have treatment for it, and as this study demonstrated, pretty good survival rates. Then Duchenne muscular dystrophy is another one. So there are exon skipping RNA therapies. So they skip the exons that are out of frame. So if you look at this picture, for example, this is the normal copy. We have 4 exons here. All 4 get encoded and they produce this functional dystrophin protein. In a patient with Duchenne muscular dystrophy, let's say, for example, exon 45 is deleted. It shifts the reading frame for the enzyme that's transcribing, translating the protein. Um, and either there's dysfunctional or no protein at all, right? So what this therapy would do is it would take a exon out that would then restore the reading frame. So for example, it could take out 44, put 43 and 46 together. And while that's not the complete protein, it's still a functional protein that's just shorter. And currently, there are four exon therapies that are FDA approved for Duchenne muscular dystrophy as well. Once again, DMD is not included in all newborn screens across the United States. And there's another trial going on as well for Duchenne muscular dystrophy. It will complete in April 2027. It is investigating a splicing oligonucleotide for skipping of exon 53. Thus far, the study has shown improvement in the biomarkers, the creatine kinase and AST, which are muscle markers. And also, there's evidence of decrease in fibrosis in the muscle cells. Okay, next one I have is the aromatic L-amino acid decarboxylase deficiency. So, this one, basically you don't produce your happy hormone, your dopamine, which sounds very sad, right? And of course, along with the emotional aspects, there's also the motor component that comes along with dopamine deficiency, right? So, this gene therapy is also an AAV-based therapy that delivers a functional gene. It is inserted surgically, just like the Huntington's we talked about earlier into the putamen, as you can see in this picture, and then produces the normal enzyme that's responsible for producing dopamine. There was an open label single arm study that showed 8 out of 12 children gained motor functional abilities after therapy when they were assessed at little under a year, 48 weeks. Then there were 3 single-arm open-label studies that demonstrated rapid improvement in motor and cognitive functions in all of the 26 patients that this study had within 12 months. And this study also demonstrated that the younger the patients, the better the outcome, if you will, or the better the progress that they saw, which I think makes sense, right? Neuroplasticity. And then in this next slide, I actually have a video of a kiddo that has this deficiency. And this is the baseline motor evaluation at 2.5 years of age. And basically what I want to point out is like, as you can see, there's very little movement, unfortunately, due to the dopamine deficiency. As we go a little bit further, they'll have him sitting on the floor. Unfortunately, as you can see, he's still not moving much. And then later on, they also have him, so as you can see, they're trying to pull him up, and there's very little, yeah, if any, really, any strength. And then later on, they have him sitting supported, so as you can see, he is not able to sit unsupported. Okay. Then the next video shows him at a 5-year evaluation after undergoing this gene therapy that we just talked about. That is a significant improvement from what we saw in the previous video, right? So as you can see, he does have some coordination issues. He does have some involuntary movements as well, but he's walking after this gene therapy, which just seems amazing. Okay. This one I included because actually they are at the federal level working to get this onto as a recommendation for all states to include since we do have therapy. So metachromatic leukodystrophy, this gene therapy is once again a lentiviral-based gene therapy, uses patients' own stem cells. In an open label trial, clinical trial of 37 children, 71% had independent ambulation at 5 years of age, and 85% had normal IQ, which we do not see with this disease. So my opinion, kind of life-changing. And then this included the eyes as well. So Leber congenital amaurosis, these patients will lose their vision gradually. This therapy does not cure vision loss. However, they did see that there was significant improvement in vision in the clinical trial at 4 years after therapy. Currently, it is FDA approved for patients who are 12 months or older, and it requires healthy retinal cells for this therapy to work. And so, once again, it would be I think it's crucial to have this on the newborn screening panel since it does require healthy cells for this therapy to work. Okay. And then some future studies. This is just an example. Like I said earlier, there are over 100 gene therapy trials going on, 70 of those being rare neurologic diseases. This is one of them. So, Crab disease, we know there's a deficiency in the enzyme, causes accumulation of the toxic protein in the brain and other organ systems involved as well. So one therapy that is being done in Spain is using a AAV vector-based therapy to introduce the functional gene via IV. And then the second study, which is being done at multiple sites, included in the United States as well, where they're introducing a functional gene, once again using the AAV vector via intrathecal, a one-time injection. And once again, these are ongoing studies, so we don't have much information just yet. But once again, just an example of how currently there are a lot of gene therapies trials going on. So, what does the newborn screening look like currently today? So, the newborn screening we know started in the 1960s by Dr. Guthrie, who first developed the blood test for PKU. And then prior to this, we know that PKU unfortunately was not diagnosed until symptoms presented, and at that point, it was too late because the brain damage that had been done, irreversible. And then as we kept going, we added more and more diseases on the newborn screen. So. We know that there's a United States recommended uniform screening panel that recommends, at the moment, 35 core conditions and 26 secondary conditions. So the secondary conditions are not, they're not testing for them specifically, but because of the 35 core, they'll also find results for those as well. Ideally, we know that the newborn screen is done in the newborn nursery in the first 24, 48 hours of life. We are once again expanding, or there's a push right now for expansion of MLD and Duchenne's as well. Unfortunately, there is variation from state to state. So right now there is the United States Health and Human Services. They would receive information from, excuse me, recommendations from the Advisory Committee on Heritable Disease in Newborns and Children, which was unfortunately terminated earlier this year. But they would provide recommendations. They were based, the committee was made up of medical experts, and they provided recommendations to the Health and Human Services, and then the Health and Human Services would provide these recommendations to the states. Currently, there are 15 million children in the United States that are affected by rare diseases. Of those 15 million, about 14,000 are identified by newborn screen. And just to provide a definition of what is a rare disease, so a rare disease, as defined by the National Organization of Rare Diseases, is a disease that affects less than 200,000 Americans. There are about 10,000 rare diseases affecting a total of 30 million total Americans. So while they are rare, they affect a huge chunk of the population. Now in Arizona, what is the current newborn screen? So currently I believe we actually follow all of the recommendations that's provided by the RUSP. We screen for 62 conditions as of last month. And then we also do a second newborn screen, usually at the newborn visit at the pediatrician, right? Not all states do that though. Arizona is planning to add Duchenne's in October of 2027. And just to kind of show you the importance of the newborn screen in Arizona, we have about 78,000 babies per year being born in Arizona with a positive result in 160 to 180 babies. That sounds small, but I think, when you get one of these diagnoses, it's obviously devastating for the families. Now we'll kind of get into some of the challenges and the reasons for why there are variation from state to state and why not all of them are tested at a state level. So the newborn screening requires obviously time. It requires resources. It requires new equipment, requires staff, requires training and education. So all of this really, in my opinion, boils down to funding, right? So we do not have probably a huge funding for these newborn screenings, right? And also in most states, there's no requirement to build a data infrastructure for reporting of screening and diagnostic results when it comes to newborn screening. Many of these conditions, unfortunately, also require lengthy testing. So, for example, I believe Pompe disease requires like an overnight stay for the staff to be there. So, once again, funding because we have to pay those workers, right, for staying overnight. Now, what could we gain from expanding the newborn screen, though? As you saw in SMA, and as we currently see clinically, if we diagnose them early, we can potentially have better outcomes. We can reduce the stressors that are placed on the healthcare system and also parents. And then, once again, SMA being the poster child, I'll demonstrate how it has also been shown to be cost effective to actually treat it pre-symptomatically. So, studied in Australia, they created a model to evaluate the costs and also quality adjusted life years. They compared that to no screening and late treatment with nusinersen, which is that antisense or antisense oligonucleotide therapy. Um, and compared to the no screening and late treatment, the ones who were treated early based on the newborn screen, they saw a gain of 85 quality adjusted life years and also $2.4 million saving per 100,000 infants. Some other challenges and controversies. So let's talk about false positives and maybe even false negatives. So false positives, what is the downside to that, right? So infants are now being exposed to unnecessary testing, costly testing and they don't have the disease, right? So on average, I read that there are about a little over 50 false positive results for every true positive result. So a lot of false positives. It's a lot of unnecessary testing. In certain diseases like tyrosinemia, the high tyrosine levels can actually be benign in some infants. And then vice versa, kiddos who do have this disease may not always have a high tyrosine level. So adjusting how we do the testing would be the answer to that, which they do. They use a different chemical they discovered that helps them reduce those false positives. We know not all mutations lead to disease, right? So not all children with mutations will develop the disease. And so we would need establishment of guidelines. How do we monitor these people? When should we treat them? Would be a question. And then also unknown long-term effects of gene therapy. This is very new. We do not have 30, 40-year long-term studies at the moment. So what are the safety concerns for gene therapies? We know that certain gene therapies can cause damage to other organs, or there's, like I said, there's those theoretical chance of oncogenesis with certain types of therapies. So what are those long-term effects, which we won't know for a while? And then costly. It is costly. And while I did show that it was cost effective, there's still treatments are still costly, right? So um, this next slide shows kind of an example of how costly it is. So nusinersen is about $750,000 for the first year, followed by 375 per year. Then Zolgensma is about $2.2 million, and that's a one-time infusion. And then risdiplam is, as you can see, a little over 13,000 for a small amount of liquid or 1130 per tablet. And this is a daily. medication. I see Dr. Mangum's question. Can families refuse newborn screening? I actually do not know the answer to that. I'm trying to think back to my Gen Peds years, and I'm trying to see if there were parents who denied, and I can't remember if they did, but I feel like there are people.
Melvin,
Yes.
yes, they can. They
Okay.
can.
Thank you.
And they have.
Okay. And so what are some of the ethical and policy considerations, right? So who gets to decide which diseases to add to the newborn screening panel? So like I said, we did have that advisory committee, which was terminated earlier this year. And so I guess now the question is who is deciding what diseases to add to these newborn screen panels. We have to think about we have to balance the cost effectiveness with also the rarity of the disease as well, right? So while there can be passionate advocacy, if there is no treatment for it, should we include it in the newborn screen? How does that change anything? What does that add to the picture? Once again, how do we address the stressors that families will face if we were to add diseases that we don't have a treatment for, or those that we just do watchful monitoring for, right? Because families will rightfully ask, well, why can't we just treat them? And then, of course, should pharma companies influence newborn screening policies? So some future things to consider. Expanding the use of next generation sequencing is a thought. So this would be right our whole exome sequencing, which we do in neurology or at least in pediatric neurology all the time, right, with our kiddos with epilepsy or neurodevelopmental disorders. Um, but should this be just part of the newborn screening? And if it is, what are we gaining from it, right? Because there are a lot of variants of unknown significance. What do we do with those, right? So but that is a potential for the future. We can also do more CRISPR-related therapies as well. And then one thing we think, excuse me, I think one thing we can all agree on is that having a universal newborn screen, standardization across all 50 states. I did not read on each state, but I think the lowest one that I saw was 33, and I believe that was Louisiana. Um, Yay, go Southeast. And I think the most was like in the 70s with New York. And once again, Arizona does 62, so we do a decent amount as well. But if we had a universal newborn screen, I think that would be very helpful for the diseases for which we do have treatments, such as MLD and Duchenne's, which once again are not included in all states. And so, to kind of end on a positive note, so if we return to the vignettes, we know that the kiddo who was diagnosed with SMA earlier did much better. And while that was a false scenario, it is the true reality that we see now. And in the video, as we saw with the dopamine enzyme deficiency, the kiddo started walking, right? So, there's a lot to gain from newborn expansion in gene therapy. And so that is my argument. So yeah, and there's just a summary slide. We know gene therapy has transferred many diseases such as SMA, and we're continuing to expand. And I believe the key to that is going to be a universal newborn screening. But we do have to consider some of the other issues that are involved, such as ethical, financial, and logistical challenges that come along. Um, yeah. So, any questions or anything that anyone wants to add?
That was a great talk, Dr. Modi. Thank you. It was very, very thorough and a good review. I think one other thing to note, you mentioned that in 2027, Arizona's adding Duchenne's, but next year, we're also adding Krabbe's to the newborn screen. So that'll be there. And the other point I want to make is that, I think universal screening sounds great and lovely and wonderful in a lot of ways. I think my difficulty wrapping my head around it is the number of medical deserts out there, right? What we see as treatment opportunities and have available as treatment opportunities here as Phoenix Children's is vastly different from what people have access to in a number of different states. So you can imagine if a family even has to drive 4 to 5 hours for decent medical care, access to resources, and then that system doesn't even offer the therapy, right? That's difficult, right? When you're testing for these and letting them know your child has this, but you'd have to fly across states to get the treatment. That's a tough situation. So I think that's where I sometimes have difficulty wrapping my head around it.
Absolutely agreed. Yes, yes. There's the challenges of exactly the burden that the families would face. Can they even drive or fly to these different locations to receive these therapies? Absolutely.
Hey, Bub and Jay Houtman. So I'm going to ask you a hypothetical, and I'd love to get your reaction. Okay, so you're seeing a child in clinic, and they have a rare form of epilepsy. Okay, that's been linked to a mutation that was found on whole exome that's never really been described. It's some sort of strange, variant of something that doesn't have a name. Okay. And let's say hypothetically, the parent of this child is an advocate and maybe like a foundation president of some rare disease, and they hire a company like Molecular Devices or Curia or one of these companies that does high throughput Drosophila screening of potential drug compounds that can work on this disease. Okay. And let's say this private company comes up with some drug that's like on the market. Let's say like Riluzole, right? Riluzole. Not something you would ever use for this, but they say in their high output Drosophila screen that this cures this disease. And the parents come back to you and they say, I would like you to put my child on this drug. What do you say?
I think so. Based on the scenario, the study that this company has done is on a fly, right? So I personally would not want to prescribe something based on a study done by one company on just some flies, right? So personally, I would not prescribe it, and I think we see this kind of not obviously this exact scenario, but we see this sometimes in our clinic where parents do ask for therapies that we would not recommend medically. And I think the discussion we have is there's no current scientific data or no peer-reviewed articles, no clinical trials that explain or support that this treatment works for this disease. So I think that's the approach that I would take.
What if they pressure you and say they want you to do an HDE?
Same thing. I think I would once again, I would point out that there's lack of evidence and not pursue anything that wouldn't be medically recommended.
Yeah, so I love your answer. This exact scenario happened to me my last year in Seattle after I had published some data on the different epilepsy that we were doing drug trials on. And the reason I bring it up, Bubba, is because I think we're going to see more and more of that.
Hmm.
As you can, I mean, honestly, as like mail order sequencing is a thing, and we're going to see a lot of tiering of the system with those who can afford to do this on their own and those that can't. I think we're going to see more and more of these questions pop up at our doorstep. And I think it creates some huge moral and ethical implications. Now, the parent that I'm hypothetically, not hypothetically telling you about was very well educated and runs a foundation and it's centered around her children.
Hmm.
And she put a tremendous amount of pressure on me, not only professionally, but through my institution to do an HDE, to basically just put their kid on this drug because, in her mind, why not? And so I'm curious if anybody else on here has had similar situations. Now, grant I'm a surgeon, so it makes it a little easier for me to bow out and just refer to Bovin here, but I'm curious, is this like a thing now? Because it was a very interesting situation I found myself in.
I've never been in this situation myself personally, but I do know people who have. Specifically like it. If you're known as being an expert in genetic conditions or rare genetic conditions, and I think that like um, a lot of the centers that support that kind of research, you haven't take into account, and I think some of them like they have had to develop like some type of like ethics committees about where they get their source funding, and is this ethical that do we devote this amount of time and resources to just because these you have someone who has a child with a super rare condition, but they also happen to have happen to be billionaires, and and what the ethical implications are for that. So I think that a lot of places like they have to have ethics committees who are aware of this and how to navigate those issues.
Jen, it's super interesting, too, because I would get into this sort of academic argument with my geneticists in Seattle, who had really had no issue just putting people on one-off HDEs, and so we had a whole core that was interested in the enteropathies. And when alpelisib came to market, they wanted to prescribe it to everybody, even though the company showed compelling pharmacokinetic and pharmacodynamic data that suggested that it doesn't cross the blood-brain barrier. And they wanted to put it on all these kids with neurogenetic conditions that had known, enteropathies. And so I think one of the things that's a challenge here is like people like you or me or Bovin, we want to do this the right way. We want to do, clinical trials that are designed well, that are powered correctly. I do think there are quite a few academic geneticists out there that just want to put people on drug and see what happens to prove basically it's like hypothesis testing of an N of one. And of course, you guys all know that like you put a kid on drug and the parents come back and say, oh, he's doing better in school. And it's like, whoa, what does that mean? Right? Or they're sleeping better, And so I think it's a pickle, but I mean, I think this area that you're describing, that you've done a terrific job in the last 30 minutes of giving us an overview of is absolutely the future. It's absolutely compelling. And honestly, it's very concerning because like there are very few guardrails around all of this. Like and we're going to see more and more of this in our practice, I think. So thank you.
Agreed. Yeah, no, agreed. Yeah, I do worry about yeah, a lot of those ethical concerns that we would have. Actually, in regarding that kind of the same topic, Dr. Friedman asks current plans for prenatal treatments with select gene therapy as opposed to waiting the child is born. So I don't think there's anything going on in humans, unless if I've not found it in my research. But what I did find that there were studies done in non-human primates, and then mouse models as well, where they have done prenatal treatment with AAV vectors, and it showed that there was no change to the AAV vector, and they've even done CRISPR-based CRISPR-based editing in mouse models, and once again, there was no change in the edit that they made. So it looks like in animal studies, potentially it's a thing we could do. I don't know how that's going to translate into humans.
Well, I for one loved your talk, Bubba. Thanks for giving it. I
Thank you.
learned a
I
lot.
appreciate it.
Thank you.
Thank you.
Thanks so much, Bevin. Great job.
Thank you.
So, Bevan, one of the challenges with some of the genotype phenotype correlations is that you can have a gene mutation that doesn't necessarily translate into a specific phenotype. And one particular scenario that we're dealing with right now is the genetic therapy for Dravet syndrome, which is an ASO trial. What's nice about ASO trials is it's not gene therapy, it's genetic therapy, so you're not altering a gene. But there's still the significant potential for adverse effects, and it's a semi-invasive administration with lumbar puncture every 4 months, conceivably forever. But the challenge with SCN1A and getting to Dr. Friedman's point about prenatal testing or pre-symptomatic treatment is not all, even computer AI model predictive modeling of the SCN1 mutation doesn't always predict Dravet syndrome. And you don't really want to be doing genetic therapies or ASO therapies if the child was only going to have a single simple febrile convulsion or maybe no seizures at all. So that's the challenge we're facing with this trial, is that we're only doing it for pretty severe Dravet syndrome, and they have to phenotypically have Dravet syndrome, which is why the trial doesn't start until year 2. It would be nice to be able to offer genetic therapy pre-symptomatically, but for something like the SCN1A mutation and Dravet syndrome, I think we're a ways away from being able to offer it pre-symptomatically.
Yeah, agreed. Yeah, Dr. Wolfong. I think, yeah, that was one of the challenges that I think we face with some of these diseases. Like you said, the genotype does not necessarily translate to the phenotype, right? So, yeah, I think that is obviously a concern. And let's say the newborn screen finds this mutation, we tell the family, and right, then now we've kind of opened this box of we're going to monitor, we're not going to start treatment, and then the big discussion would be, well, why can't we just treat it pre-symptomatically, right? So, yeah, that would be that is a hurdle we would face. Yeah.